Thank you very much, Martin, and thank you to Barry for that very thought-provoking introduction. And yeah, I was really struck by the painting, and actually it takes us back to the reality of general practice, which is about life, death, illness, and really important things. And actually a lot of my work fades into insignificance compared with that everyday reality of general practice and what you see. So this is a great privilege for me to be invited here today as an NHS manager to the LMC and CPEN Study Day. So thank you for giving me some time on your agenda. I would say, of course, that the role of administrators in the NHS is to support the clinicians, and I think sometimes we've slightly lost sight of that. What I want to do this morning is, if I can, is to respond to some of those challenges which Barry's very clearly set out, and explain some of the practical things that we're doing to help you to serve your patients, some of the things that are going on now and some of the things you can expect to see over the coming months. So as I said, it's really important to ground this in the actual reality of clinical practice and everyday service delivery. If we go back to the purpose of medicine, it's to reduce human suffering, and of course general practice adds to that a sense of making sense of people's own lives within their own context, and of course it's different in that respect to some other elements of medicine. And that's not just delivered by GPs, it's delivered by the whole practice team, the receptionists, nurses, healthcare assistants, managers and so on. That orientation to helping people with their own lives is really quite critical, and I think often it's an overlooked dimension of general practice. We focus so much on some of the numbers, GP numbers of consultations and so on. I think it's really important that we remember that it is all about helping people to make sense of their own lives. So thank you for the work that you do, and please don't underestimate the impact that you're having every day. Most of my work, well, quite a lot of my work involves dealing with things that have gone wrong, but it's worth reflecting that actually most of the time things go right in general practice in Somerset, and despite all of the challenges, patients are still getting overall a fantastic service. So let's remember that and let's celebrate it. So we're all here, I hope, with a shared desire to reduce human suffering. But what about the suffering of the practitioners and the other members of the practice team? I think, you know, it's a tough job, isn't it? Let's not avoid that. So it's a tough job delivering general practice, whether you're a GP or another member of the practice team. It's not an easy job. In many ways, it's got harder over the last few years. We know that. But what can we do? What can we do that will help patients, but it will also reduce the misery factor and increase the joy at work factor? And I think there's quite a lot of things that we can do. So I'm optimistic, and I'll admit that straight away. You can decide whether I'm diagnosable or not later when you've heard what I've got to say. So let's take the findings of that GP review then that Barry mentioned. That was a piece of work done as part of the health and care strategy, led by Steve Edgar and Will Harris as clinical leads, with a bit of help from me. That came up with three main findings, that piece of work. The first was that continuity of care in general practice is of prime importance, not just to the health of the population of Somerset, but also to the well-being of the health and care system in Somerset. Secondly, there's widespread variation between practices on a whole range of indicators, some of which are trivial and insignificant, and some not. And thirdly and finally, we concluded that there's a need to organise general practice in a way that offers the optimal benefits to patients, and that rather than accepting at face value the idea of primary care at scale, as promoted by our colleagues in NHS England, that we ought to think, we ought to use a logical model and a proper theoretical underpinning to inform our discussions about what we think the future of general practice in Somerset looks like. So each of those areas actually, if you think about it, offers great scope to make the working lives of GPs and other members of the practice team better. So if we think about continuity of care, it's interesting, Barry's pie chart of who patients are seeing. Actually, the majority of consultations still were with GP rather than another member of the practice team. Now, I'm old enough to remember when GPs practiced from their houses, and one of the interesting things is not just the level of change in general practice, but also the level of continuity and tradition. So there are still practices where the overwhelming resource is the GPs themselves, and they're aided by a very small number of receptionists, nurses, possibly others. But essentially the service on offer to patients is see a GP. And I remember when I moved to Somerset from Bristol in 2013, I was quite surprised when I registered with my local practice, and the first time I needed to see someone, I rang up and I was automatically booked in to see a GP without any sort of further negotiation. I'd come from Bristol, where you had to fight your way past a security guard and three layers of triage before you ever got anywhere near a GP. So that was interesting. But most practices have come to the conclusion, either reluctantly or enthusiastically, that traditional model where the GP is the service to patients, actually it's not sustainable, and there needs to be some changes. Some practices have moved very quickly, some practices have moved slowly. And of course, one of the great strengths of general practice is the ability to be agile and to change things quite quickly. So I think change is in the air, but what sort of change? So some practices are combining a team-based model of continuity of care with a high level of GP continuity, where the GPs oversee a multidisciplinary team. And that's quite different to that traditional GP-only model, but I think actually is a way of preserving the benefits to patients of the GP-only model. Was there anything wrong with a GP-only model? Very little. So we're responding to changes and developments as they happen, rather than saying what we've traditionally had doesn't work, we need to do something completely different. It's about adapting and evolving. But if we think about continuity, that traditional GP continuity, we all know it is challenged by the growth of part-time working, a whole range of factors. So we can't turn the clock back. But when you look at the evidence about the relationship between continuity of care and population health outcome, it really is quite striking. And so we can't ignore it. It's linked directly to population level mortality and health outcomes, individual level health outcomes, including things that are really important and make a huge difference to patients' lives, like location of death and emergency admission. But there's been a decline in relationship continuity of over 25% between 2013 and now. So continuity of care in general practice isn't a given, and if we're not careful, and I think there are some red herrings which we could follow that would actually remove continuity of care altogether. That would be a disaster, both for patients but also for the wider health and care system in Somerset, and I think it would be bad for GPs and practice teams as well. So what can you do about continuity of care? Well, actually quite a lot. The practice where I'm registered actually has a team-based approach to continuity of care, where there are health coaches working very closely with the GPs, and also has a high level of that interpersonal continuity, in that GPs are at the beginning of the process. So it's GPs that are speaking to patients and understanding their problems, and then handing some of those tasks on to a wider multidisciplinary team under the oversight of the GP. And I think that kind of modern high continuity approach actually delivers good results for patients, but is also a satisfying environment for GPs and other members of the practice team to work in. But of course it's not easy to do, And some practices have gone a long way with that kind of model. Some have made a start, some are finding it quite difficult. So one of the things that we're going to do is, working with the GP board and with the education provider network, is to organise some training and education for GPs and other members of the multidisciplinary teams based on real life experience and examples from Somerset, to help practices to be able to organise effectively that kind of multidisciplinary team work. So continuity of care, I think we could talk a lot about continuity of care. Actually, it would make a good theme for a whole day's event, and I think we need to be very clear how we promote continuity of care. I don't think we can avoid the fact now that all of the research evidence is pointing to continuity of care as being a critical success factor, not just for primary care provision but also for wider health systems. The Nuffield Trust produced a new report just a couple of days ago. It's well worth having a look at if you're interested. So it's continuity of care, but not in a way that adds to the additional burden of GPs in particular, because we're still seeing GPs having the majority of consultations. And if you look at the growth in consultation numbers, which Barry referred to, actually one of the striking things, and there's a paper in the Lancet a couple of years that shows this quite starkly, is that the number of consultations for other members of the clinical team actually have remained static over recent years. And that increase in demand actually has been soaked up by the GPs. So the number of practice nurse consultations in most places has remained more or less static. And it's the GP consultations that are going through the roof. And of course that varies by practice. That was a national paper. But there's something to think about there. How do we make working lives better in a way that also delivers for patients? And I think there's an awful lot of expertise in the room about how we do that. So it's not for me to tell you, but hopefully we can work together and do some of those things together that will make a difference. Will also make working lives better. So that was the first conclusion of the work that we did looking at GP services. The second area we looked at was variation, and of course people always tend to think about this as a sort of performance issue, and the CCG is going to come and visit and kind of grill you about why you're not doing as well as we think you ought to be. But actually, when I look at variation, I'm not so much taken by the differing performance, if you like, but actually the kind of the reality behind those figures. So one of the things I often see when I visit practices, and I try and get around and out of Winford House as much as I can, is GPs trying to do it all, and inevitably they can't. And if we take one case in point, clinical administration, the amount of correspondence that GPs are looking at in practice in Somerset varies enormously. Between 100%, we've got GPs looking at every single thing, down to under 40% in some practices. So that's an area where I think we've made some real progress. I think the LMC supported training and workshops on clinical workflow and document management have been a real help to some practices, but I think we can do more to help with that kind of process efficiency development, to make lives as simple and easy as possible, and to allow clinicians the time that they need to care for patients. And that leads me on to my next point, which is that when we look at general practice in England, there's a paradox which is apparent to me and probably to you, that English general practice offers probably the widest range of primary care services of any primary care physician set up in the world. The range of services provided by practices are very, very comprehensive, which is great for patients. And yet, when we look at the practice teams that are trying to deliver that comprehensive range of services, they're tiny. And if we compare them with other provider organisations, actually, what you see in most cases is a lack. So you see a lack of formal training and capacity in quality improvement, strategic management, clinical redesign, financial analysis, business analytics, HR, and so on. And frankly, it's a testament and a tribute to the work that you do every day that so much goes so well so much of the time, because actually there is a dearth there of capacity and resource to do the very complicated set of things that we're asking you to do. And so I think there's real opportunities to try and fill in some of those gaps in a way that works for you, not imposing models, but trying to make sure that those resources are available to you. And we'll come on to how some of that might work a little bit later when we're thinking about neighbourhoods. And there are some positive developments, I think, in Somerset that are potentially vehicles for some of these things, because of course at an individual practice level it's very difficult to have significant capacity in IT development or HR or analysis of trends in utilisation, and how many patients you've got coming and how many are coming frequently, and what are they coming for, and all those sorts of questions that I think we need to answer. So at this stage I'd like to make clear that bigger isn't necessarily better, and that's why we think that we need some clear thinking based on logic rather than just embracing the idea of primary care at scale. And that's why the report that Steve and Will and I worked on concluded that we need to think about organised primary care as opposed to primary care at scale. So there's nothing wrong with big practices. There's nothing wrong with small practices. There's no single answer to the challenges facing general practice, and anyone who tells you that there is I would suggest being tendentious at best, because it's complicated. So what we need to do is to think clearly about what are the opportunities, what can we do to help ourselves and to help our patients. So what do we mean by organised primary care then? Is it just another phrase? Well, no, it isn't. And what it means is going back to the benefits of general practice. And I'm sure if I quizzed you on your alma mater declaration or your Wonka statement of the benefits of general practice, you'd be able to recite them en masse, and that would be a lovely thing. But just for anyone who is a little bit rusty, I have listed them on this slide. And actually, when we think about how healthcare systems work, these benefits really are quite striking, actually indispensable. And that's the reason why the World Health Organization prioritises primary care development. In every developing healthcare system in the world, the advice of the World Health Organization would be, don't build hospitals, build primary care. Start with people themselves and their communities, see what you can do to help people, and then build your skills and expertise and capacity in the place where it has the biggest return on investment, and that is in the community. There's no doubt about that. So, this is a pretty impressive list of benefits, and I have to say I do spend quite a lot of my time explaining to colleagues in the wider healthcare system that this is what general practice actually delivers for us in Somerset. So if we think about the organisation of general practice and we ground that in these benefits and how do we deliver these benefits optimally, then I think we won't go too far wrong. And for me as a Commissioner of General Practice, I suppose I've got a role in this because I'm the person with the money, not enough money no doubt, but some of the money, and we want to get that money into the right places and invest in the right clinical services. So that's why we've got an interest in how general practice is organised and what the future looks like. Of course, you as providers, there's a question for you about how you want to organise yourselves in order to deliver these benefits. So I want to just kind of hammer home that point, actually, that it's not for the commissioners to dictate the organisation of general practice. So you're not going to be forcibly merged into 30,000 patient super hubs. And I said there's nothing wrong with 30,000 patient practices, and there's nothing wrong with 3,000 patient practices. So probably some of you will be relieved to hear there is no secret plan to force you to do something that you don't want to do, and dictate the model of organisation of GP services. And probably some of you are appalled because you actually want someone to tell you what the plan is, so you can actually form up and go and get on with it. So you can take your own conclusion really from what I've said. What I do think we need to do is to help colleagues in practice to be clear about the range of options that actually exist, and whether you are interested in super partnership covering 50 or 100,000 people, or whether you're running a small independent practice and you wish to remain doing so, actually there is more we could do to help you to understand the options and the things that will help you in years to come. And I think that we will be doing more of that in the coming months. And I know that both Andrew and Burge are speaking later about some of the options on offer. And of course, at the moment, the majority of practices in Somerset are run by independent contractor GPs working in partnerships. And that's a model that, as Barry's illustrated, goes all the way back to 1948 and beyond to 1911 and even further back than that. Now, I know there's been a lot of talk about the partnership model, so I wanted to say explicitly that much good has come of the partnership model, and I think we should honour and respect it. Intelligent, compassionate doctors have been at liberty to organise their practice as they see fit in order to benefit their patients. We know that that model is under real pressure from many different directions, some of which are more amenable to intervention and common sense than others. And of course, we're all interested in the outcome of Nigel Watson's national review into the partnership model. But I think as well we need to make sure that we're not passive bystanders in the process. So I've been put on the spot to come up with a Karl Marx quote. I'll try not to disappoint you. One of my favourites is, humans are free to make their own history, but not in circumstances of their own choosing. So we're in a context for general practice in Somerset. It's pretty tricky. Question is, well, what are we going to do? Here we are in the context that we have. What control have we got? And actually, there are quite a lot of things that are within our gift locally to choose. So appointment times is one example, appointment length. Actually, frustratingly identified way back in about 2000 as being one of the key predictive variables of quality in general practice, and yet hasn't really been responded to by policymakers. Consultation length actually is very important, and we've got some practices that are doing 15-minute appointments as standard. There's a huge range of variation, but I think critically the point is that it's for you to choose how you organise your appointment length. And of course there are implications for how you do that, but it's one area amongst many where I suppose my message to you is you do have actually a lot of freedom and control in the way that you organise practices and the way that GP services are delivered. Anyway, so we've got a range of challenges facing us. I think there's quite a lot of different opportunities and solutions to those challenges. I think overall I feel sufficiently positive about general practice in Somerset to say I think we could have a renaissance in general practice. I think the time's right actually to get on the front foot and start doing some things. Anyway, I said I'd talk about practical things, so I wanted to tell you about some of those things that are going on. So you may be aware already of the practice support team hosted by the LMC, made up of experienced GPs, practice managers. It's been going out supporting practices on an entirely confidential basis. I have no idea where they've been. That seems to have really helped, so there'll be more money to expand that team, and every practice will be able to access that support at no cost whatsoever. As I said, completely confidentially. Going beyond that and thinking about best practice and innovation and how it spreads, and it's always been a difficulty for the model of general practice because it's made up of so many small individual providers for innovation to move quite quickly and to be adopted. There'll be a dedicated project to share best practice. So the clinical workflow example I mentioned is just one good example. So if you're just getting started on it, thinking, that's something we'd like to do, we want to reduce the number of documents that GPs are actually having to read, what you can expect is having an experienced colleague from a practice that's at the leading edge of this to visit, to give you advice, and there'll be project management resources to help you get started. So you won't be alone with these things. And I think that sense of general practice in Somerset as a community and trying to do things together, both between the commissioners and the providers, but also the provider sector and working with the GP board as the provider voice is going to be a key theme, I think, for the coming years. So that's a project which I think will help see some good results there. That'll be led by SPH and supported by the GP board. In general terms, I think there's a lot that we can do if we look beyond the traditional practice boundary. If we start thinking about general practice as a sector rather than as a large number of providers, which in many cases are too small to do the things that we would like to do. So, for example, we want to attract more GPs to Somerset. Barry was modest enough to not to mention that he actually was successful in recruiting an international GP to come and work in Taunton. We hope that there'll be more international GPs coming to join us. The LMC have run a fantastic campaign GP in Somerset, and that's been successful in attracting a number of GPs. Other GPs have been attracted by innovative models on offer, both at practice level, also SHS and Taunton and Somerset. But one of the areas, as you know, that's difficult for GPs when they want to make a move is all of the bureaucracy and form filling and performance list issues and prescriber numbers and so on. So we're going to put money into a new GP concierge service that will help any GP that's expressing an interest in coming to work in Somerset to match them up with practices that they might like to work in, to take care of all the bureaucracy, get them sorted out on the performance list and all the rest of it, even help them to find somewhere to live or a school for their children, to make it as easy as possible for new GPs. And we'll look at other workforce areas as well where we can make a difference with that kind of service. So we will do all that we can to increase the number of clinicians joining us in Somerset. Of course, it's not just enough to attract new GPs, we also need to hold on to the ones that we've got. So we'll put more money into the GP Careers Plus scheme to ensure that those GPs who are looking to retire earlier than planned have a discussion with an experienced and senior GP to explore reasons for retirement and see if there's any changes that we could put in place to allow them to carry on working. And that's that development is being led by SPH and the LMC. There'll be more information soon. I would say that that scheme has been outstandingly successful in a number of GPs who have been tempted to stay in the workforce by the exciting clinical opportunities that have been organised by Rachel and her team, and the peer support that's available to those doctors. And one of the things that really strikes me is how little peer support there is available for GPs these days. It can be quite a lonely and isolated job, and this is just one thing that we need to do in order to improve things. So if you'd like to hear more about that, then do talk to Rachel. There's a huge amount of ideas that are bubbling up. This feels like a fertile time in general practice in Somerset. So there's all sorts of things that we're looking to do, and we'll put money into seeing if they've got legs. So one is digitisation of all remaining paper records to free up space in practice for consultation space. A county-wide complaints management service for practices is another idea that we're looking at. And another area which I think may well be fertile is providing money for practices to engage experts in access redesign. Because we all know that access has got the potential to be a real misery factor. And if the patient is coming into the consultation grumpy because they've had a difficulty in actually getting to the clinician, then that's not a great starting point for that consultation. So we've done quite a lot. We can do more. I've mentioned some of the things that we'll do that will help individual practices. I wanted to set that in the context of neighbourhood teams if I can. Now, the first thing to say that it's probably worth trying to be clear what we mean by the term neighbourhood and neighbourhood teams. So there's a picture here, and you'll see that there are six distinct elements. So first of all, there's a defined place. Secondly, there's population, and you'll hear more from James Kingsland later about optimal size for locally integrated care, but it's got to be small enough that people have got a chance to get to know each other, the GPs, the community nurses, everyone else involved. There's an ethos of working together and collaborating for the benefit of patients, and that's quite different for some staff in some of the organisations in Somerset now. The idea that if it's legal and it benefits patients, it's okay to get on with it. It's going to take us some time to get there. And then there are 3 specific service elements. So there's integrated community services, including complex care. There's social prescribing and kind of community well-being activities, things that can get people out of medical pathways as quickly as possible. And then there's enhanced GP services that have got the capacity and the right skills and all the right resources to do what we're asking of them, to have that high continuity, proactive approach. So you can see that although the idea of a clinical neighbourhood or a neighbourhood team in some ways is simple, actually it's got a number of elements, each of which has its own complexities. So it's going to be a big programme to deliver this. I'm excited about it. I'm old enough to remember fund holding and GP co-ops and the excitement and enthusiasm that you can unleash if you get GPs interested in something and thinking this is something that's actually really worth putting some energy into. So what can you expect to see? First of all, we've asked the National Association of Primary Care to come in and help us. You'll hear from James Kingsland later on. But in practical terms, you can expect to see friendly, helpful faces on the ground in your local area, helping you with questions and issues like how do you integrate better with other services, how do you get those other services to integrate better with you, what do you do about coming up with new care models that answer the questions and the problems that you've got in your own local area. So the way this is going to be organised is that Steve Edgar, who's CCG Clinical Lead for Long-Term Conditions, will be in charge of all of this. Does everyone know Steve? Could you identify yourself, Steve? It's a big job, but Steve's a big man, figuratively speaking. So if you've got any questions, do talk to Steve. It's going to be a big programme, so inevitably at times it might feel a little bit confusing. That's fine. There's going to be a lot going on. Key thing to understand is it's going to be led locally by you, but if you've got any questions, then do talk to Steve. We'll be joined by Jeremy Martin, who's previously Programme Director of Symphony in South Somerset, to help us with the implementation. But the main faces that you'll see will be the NAPC team led by Andy Mullins. So you can expect contact locally from those colleagues in the next week or two. And what they'll be helping you to do is to make some time and space to think about what the problems are that you want to respond to. We'll fund backfill, we'll fund emergency cover so that practices can close and get together, think through, get some headspace, what the issues are. We'll help you to build relationships with other players and other organisations, and we'll support you in developing agreed local objectives about what it is, what problems are there in your local area that you want to respond to. So the GP board and SPH fully involved in all of this work. You can be assured that they'll be holding us to account and making sure that GPs get a square deal in all of this transformation and change. In conclusion then, I think the challenges facing general practice in England are significant, and in Somerset we have all of those challenges. But I think with the level of expertise and enthusiasm and commitment in the general practice community in Somerset and the good work and good ideas that are currently emerging, I think there's grounds for optimism that we can make a real difference to your working lives and to the health and population health of the people of Somerset. Thank you.